Hello and welcome to the Emergency Room Podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
Welcome back to Emergency Room Podcast. Today we're tackling something that's absolutely critical in our line of work, interpreting arterial blood gases. Those ABGs that can sometimes feel like a cryptic puzzle, especially when things get really hectic.
Absolutely. It's one thing to memorize normal ranges, but it's another thing entirely to actually use that knowledge in the ER, especially when a patient presents with a really complex acid-base imbalance.
Right. And to help us really unlock the secrets of ABG interpretation, I'm joined by the brilliant Dr. Monica.
Thanks for having me. This is a topic that I'm really passionate about.
We're diving deep today into a study. The title is Interpretación de Gasometrías. Solo tres pasos, solo tres fórmulas. It's by Sanchez Diaz and colleagues, and it was published in the journal Medicina Critica. If you want to read along with the article, you can find the DOI link in the episode description. Now, before we get into the details, I want to start with a question. Can a simple three-step method really unlock the mysteries of ABG interpretation? That's what we're here to explore.
I love that question. It really gets to the heart of why this article is so intriguing.
I know you're a big proponent of systematic approaches in medicine. What initially drew you to this particular three-step method?
Well, in the ER, we're often faced with decisions that need to be made quickly. A systematic approach to ABG interpretation really helps streamline our thinking and ensures that we don't miss crucial details. This particular method, like you mentioned, breaks it all down into three clear steps, each one building on the previous one.
Okay, let's break it down then. Step one focuses on what?
So step one is all about the pH. It's our first clue. It tells us right away whether the patient is in acidemia, meaning a pH less than 7.35, or alkalemia, meaning a pH greater than 7.45.
So we established the overall acid-base status. What's next in our detective work?
Okay, so step two. Step two zooms in on the respiratory component. By looking at the PaSO2, that's the partial pressure of carbon dioxide, this value tells us how effectively the lungs are regulating the acid-base balance.
Okay, so a high PaSO2.
Yeah.
Let's say above 45 millimeters of mercury. That would point to?
That would indicate respiratory acidosis, meaning that the lungs aren't removing carbon dioxide effectively, which leads to an acid buildup. Conversely, a low PaSO2, like below 35 millimeters of mercury, suggests respiratory alkalosis. This means the lungs are eliminating too much carbon dioxide, which is making the blood more alkaline.
Okay, that makes sense. So we've got the pH laying the groundwork. PaSO2 is giving us the respiratory picture. What's the final piece of this three-step puzzle?
All right, so step three. Step three delves into the metabolic component by examining the base excess. Now, base excess can be a little tricky to grasp, but it essentially reflects the amount of acid or base that's been added to the blood by the kidneys or other metabolic processes.
So it's like a measure of the metabolic system's attempt to compensate for any acid-base imbalance.
Precisely. And what's fascinating is that base excess doesn't just tell us about the metabolic component, it can also provide clues about how long a respiratory disorder has been going on. The chronicity.
Okay, now that's where it gets really interesting. How does base excess tell us whether a respiratory problem is acute or chronic?
Okay, so imagine a patient comes in and they have an elevated PaSO2, indicating respiratory acidosis. Now, if their base excess is within the normal range, let's say between -2 and +2 milliequivalents per liter, it suggests that the kidneys haven't had enough time to compensate. This usually means an acute respiratory problem.
So the body is still in the early stages of trying to restore balance.
Right. But if the base excess is significantly outside of that normal range, it tells us that the kidneys have been working hard to compensate, either by retaining bicarbonate in the case of acidosis, or excreting it in the case of alkalosis. This usually indicates a chronic respiratory issue, like COPD.
That's a brilliant insight. So base excess isn't just a number. It's a window into the duration and severity of the respiratory problem.
Exactly. It's about seeing those ABG values not as isolated data points, but as pieces of a larger physiological story.
That's a great way to put it. Now, we've covered the three steps, but the article also mentions these three formulas that play a key role in this method. Let's unpack those.
Absolutely. These formulas really take the guesswork out of determining if the body is compensating appropriately for the acid-base disturbance.
Okay, so let's take metabolic acidosis as an example. The article provides a formula for calculating the expected PaSO2 based on the bicarbonate level. Can you walk us through that formula and how it helps us assess compensation?
Of course. So the formula for metabolic acidosis is Expected PaSi2 equals 1.5 times the bicarbonate level, plus 8, plus or minus 2. By plugging in the bicarbonate value from the ABG, we can calculate what the PaSi2 should be.
And what does comparing the expected PaSi2 to the actual PaSi2 tell us?
So if the actual PaSi2 closely matches the expected value, it indicates that the respiratory system is appropriately compensating for the metabolic acidosis. However, if there's a significant difference between the two values, that raises a red flag.
A red flag for what exactly?
It suggests that we might be dealing with a mixed acid-base disorder, meaning there's more than one process going on. For instance, a patient might have metabolic acidosis, but also have coexisting respiratory acidosis or alkalosis.
So the formulas act like a check and balance system, helping us make sure that our initial interpretation, the one based on the 3 steps,
Right.
aligns with what's actually happening physiologically.
Precisely. It really adds a layer of precision and helps us avoid oversimplifying complex cases.
Now, before we move on to a specific case example, I want to touch on a point that the article mentions briefly, but I think it deserves more attention. It's this idea of adjusting ABG values for altitude. I've always found that to be kind of a gray area.
Yeah, it's definitely something that's often overlooked, but it can have a big impact on our interpretation, especially when we're dealing with patients who live at higher elevations or have recently traveled to mountainous regions.
Right. We can't just apply the same sea level standards to everyone.
Exactly. For example, at higher altitudes, the partial pressure of oxygen in the atmosphere is lower. This means that a patient's PaO2, that's the partial pressure of oxygen in arterial blood, will naturally be lower than someone at sea level, even if their lung function is totally normal.
So if we don't take altitude into account, we might misinterpret a lower PaO2 as hypoxemia, when it's actually a physiological adaptation to the environment.
Exactly. And the same principle applies to other ABG parameters, though the adjustments might be more nuanced. The key takeaway is that context matters. We need to consider the patient's individual circumstances, including their geographic location, when we interpret their ABG results.
I think that's a crucial point to emphasize, especially for our listeners who practice in regions with varying altitudes. Now, let's get down to brass tacks and see how this 3-step method works in action. The article presents this case of a patient with diabetic ketoacidosis, which, as we know, can lead to significant acid-base imbalances. Are you ready to walk through this case step by step?
Absolutely. Let's put our knowledge to the test.
Perfect. We'll start by revealing the patient's ABG values, and then we'll apply the 3 steps and the relevant formula to arrive at a diagnosis and assess the adequacy of compensation.
Okay, let's hear those ABG values for this patient with diabetic ketoacidosis.
All right, so our patient presents with a pH of 7.25.
So right away, we can see that the patient is in acidemia, with a pH below that normal range.
Exactly. Next, we have the PaCO2, which comes back at 28 millimeters of mercury.
Interesting. So that's below the normal range, 35 to 45 millimeters of mercury. This indicates respiratory alkalosis. So it seems like the lungs are trying to compensate by blowing off carbon dioxide to increase the pH.
Now for the final piece of the puzzle, the base excess. It's mid 10 milliequivalents per liter.
Okay, so that is significantly below the normal range of -2 to +2, pointing towards metabolic acidosis. So we're looking at metabolic acidosis with partial respiratory compensation. That low PaCO2 shows that the respiratory system is trying to counteract the acidosis, but it hasn't fully corrected it yet.
And because the base excess is abnormal, we know that this isn't an acute respiratory problem. The kidneys have had time to respond to the metabolic acidosis, probably by excreting bicarbonate to try to bring that pH back to normal.
Right. To confirm our suspicions and assess how well the body is compensating, let's use that formula for metabolic acidosis.
Good idea.
Yeah.
So the formula, if you recall, expected PaO2 equals 1.5 times the bicarbonate level, plus 8, plus or minus 2.
Yeah.
Now, the article didn't give us the bicarbonate level directly, but we can tell it's low because of the metabolic acidosis. So let's just assume for this example that the bicarbonate is 10 milliequivalents per liter.
Okay, so plugging that into the formula, we get an expected PaCO2 of 23 millimeters of mercury, plus or minus 2.
And our patient's actual PaCO2 is 28 millimeters of mercury.
Yeah.
So the actual is higher than what we'd expect.
Right. That means the respiratory compensation is only partial. It's not fully correcting the acidosis, which makes sense, given how severe the metabolic disturbance is. Cases like this really highlight how useful these formulas can be, in confirming our initial assessment and really getting a detailed understanding of the acid-base balance.
It's like having a mathematical compass to guide us through these really confusing waters of ABG interpretation. Instead of just relying on intuition, we can base our decisions on this concrete analysis.
I couldn't agree more. It really adds a layer of objectivity to our assessment. No. We were talking about adjusting for altitude before. Do you think that would be relevant in this case?
That's a great question. The article doesn't say where the patient is or if they've traveled recently, but it's always something to keep in mind. If this patient lived at a high altitude, we might expect their PO2 to be lower than someone at sea level.
Right, and that lower PO2, it wouldn't necessarily be a problem with their lung function, but more like a normal adaptation to the lower partial pressure of oxygen, at higher elevations.
It's a good reminder that interpreting ABGs isn't always black and white. We have to think about the context, the individual patient, and their specific situation.
Absolutely. It's about looking beyond just the numbers and seeing the bigger picture.
Yeah.
Now, shifting gears a bit, I'm curious to hear your thoughts on the Stewart approach to acid-base interpretation. The article just mentioned it briefly, but I think it's worth exploring.
You're right. We can't just skip over it. The three-step method is great. It's practical. It's simple. But the Stewart approach, it offers a different perspective on acid-base balance.
Exactly. The Stewart approach is more comprehensive. It considers all these factors that can influence pH, like strong ions, weak acids, and of course the partial pressure of carbon dioxide.
It's definitely a more nuanced approach.
Yeah.
Maybe even a little complex. But it can be really helpful in those complicated cases where the traditional approach doesn't give us all the answers.
Exactly. For example, in cases with severe electrolyte problems or poisoning, the Stewart approach can give us a more accurate assessment because it considers all those extra factors.
It's like having a stronger microscope. We can see all those finer details of the acid-base picture. But as the article points out, the Stewart approach can take more time, and it can be harder to understand, which might make it less useful in a fast-paced environment like the ER.
That's true. The three-step method, with its straightforward steps and formulas, is definitely more streamlined. It's perfect for quick assessment and decision-making in emergency settings.
I think it's all about choosing the right tool for the job. The three-step method is like a workhorse. It's great for most cases, but the Stewart approach is a valuable tool to have for those really complex or confusing cases.
Well said. It's all about having lots of tools and knowing when to use each one.
Now, before we wrap things up, I want to go back to that question I asked at the beginning. Can a simple three-step method really unlock the mysteries of ABG interpretation?
What do you think? After this deep dive, has it lived up to the challenge?
Honestly, I'm really impressed. This three-step, three-formula method really does break down ABG interpretation. It's so manageable and logical. It's like a roadmap. It guides us through each step, from the pH to the respiratory and metabolic parts, and even helps us figure out if the body is compensating the right amount.
I totally agree. It's simple, but it really works. And like we talked about, the formulas give us this extra level of precision, which is so important when you're working under pressure in the ER.
Yeah, it really takes out the guesswork. And you have solid data to support your decisions. Now, before we wrap up, I want to give our listeners a little challenge, something to think about, a case to really put this ABG knowledge to the test.
I love that. A little mental exercise.
Okay, so imagine this. You're in the middle of a busy ER shift, and a patient comes in, shortness of breath. Altered mental status, you get the ABG results back, pH of 7.50, PaSO2 of 30 millimeters of mercury, and a base excess of +4 milliequivalents per liter. How would you approach this case using the three-step method? What would be your first thought? We won't give away the answer, but try applying the steps we've discussed. Really think about it. Maybe even use those formulas. See if you can crack the code.
It's a classic case. One that really makes you use your knowledge of acid-base balance. If you remember those three steps and the three formulas, you'll be able to figure out even the toughest ABG situations.
Dr. Monica, this was so insightful. Thank you so much for sharing your expertise with us. I know our listeners are going to feel so much more confident about ABG interpretation.
The pleasure was all mine. I'm always happy to make this topic a little less scary.
And to all of you listening, thank you for joining us for this deep dive into ABGs. Be sure to check out the episode description. You'll find the DOI link to the article we discussed. If you found this helpful, please share it. And subscribe to Emergency Room Podcast for more evidence-based insights from the front lines of emergency medicine. Until next time, stay curious, stay informed, and stay sharp.